Good day, everyone, and welcome all. Thank you for joining us tonight in the SIOG 2021 webinar series. I am Anna Mislang, a medical and geriatric oncologist at Flinders Centre for Innovation in Cancer in South Australia, and I am the co-chair of the SIOG COVID-19 working group. The working group was established in March 2020 when emerging data indicated high risk for devastating outcomes in older adults affected with COVID-19 due to their age, comorbidities, and other geriatric factors. Our aim is to develop consensus, recommendations, and action plans based on expert opinion and available evidence related to and applicable to geriatric oncology. The panel consists of various international experts from different specialties, and 3 of them will be our key speakers for tonight. A month ago, we published the working group recommendations on the rollout of COVID-19 vaccines among older adults with cancer in the Journal of Geriatric Oncology, and is free to access for all. Dr. Nicola Battisti is my co-chair in the working group and will be my co-host for tonight. He is also a medical oncologist working as a clinical fellow at the Royal Marsden Hospital in London, UK. He has great experience with geriatric oncology and is the SIOG president-elect. Good day, Nicola.
Thank you very much, Anna. Thank you very much, everybody, for being here today. As Anna said, I co-chair the SIOG COVID-19 working group, and it's my pleasure to welcome you all here for this webinar on the hot topic of COVID-19 vaccinations for older patients with cancer. Being older and having a diagnosis of cancer obviously makes these specific populations of the individuals doubly disadvantaged when it comes to outcomes of COVID-19 and of cancer management during this pandemic. Therefore, it is key that older adults with cancer are prioritized for the rollout of the vaccination programs worldwide, as we have recently outlined in our publication on JGO. Today, we have a fantastic lineup of speakers that will present the data available on the COVID-19 vaccines and discuss them in the context of the complex needs of older adults with cancer. In keeping with the multidisciplinary healthcare professional representation within SIOG, our speakers have different backgrounds, but they have great expertise on the management of older adults with cancer and share the same passion to improve outcomes for this specific population. Let me remind you a few housekeeping rules. As you know, we will have 3 presentations, 15 minutes each, followed by a Q&A session. Please make sure you pop your questions in the Q&A box available here on Zoom. Dr. Mislang and I will monitor the box, and we are happy to relay your questions to the speakers during the Q&A session. With no further ado, let me introduce the first speaker. Dr. Chiara Russo is a geriatrician of the Geriatric Oncology Program of the Lyon-Bérard Comprehensive Cancer Center in Lyon, France. Dr. Russo completed a specialty training at the University of Genoa, Italy, and obtained a PhD on the role of geriatric intervention during anti-cancer treatment in older patients at the University of Genoa and Lyon-Bérard. In 2016, she also obtained a geriatric oncology certification there. In 2019, she graduated from the SIOG Advanced Course in Geriatric Oncology in Treviso, Italy. She's an active member of the SIOG and our COVID-19 working group and of the French Society of Geriatric Oncology, SOFOG, since 2015. Dr. Russo will review today the efficacy data supporting the use of COVID-19 vaccines in older patients with cancer. Thank you very much, Dr. Russo. Over to you.
Thank you, Nicolo. Thank you, Anna. Good morning good evening to everybody. I am honored to be here this evening and to present to you the COVID-19 vaccine efficacy data supporting the role for the patient with cancer. Coronavirus disease affected tens of millions of people since it was declared a pandemic in March 2020. Elderly patients, people affected by comorbidity and cancer are at high risk of COVID and complication. As shown in this paper, compared with survivor, cancer patients who died were more frequently aged. The impact of COVID-19 on cancer care has resulted with a decrease and delay in cancer care diagnosis with, diagnosis I'm so sorry. Is the problem? No. I'm so sorry. I try to. Yes. I'm really sorry. But I have no problem until now.
I think the SIOG head office is sharing the slides.
Okay.
Chiara.
Okay.
So
okay.
feel free to
Okay,
next slide and yeah, thank you.
Sorry. Okay, so I wait for. I have to wait for. Okay. Thank you. Perfect. Thank you. Okay. Most of vaccines are in the development in this moment, but even if the most part of trial make the effort to include elderly cancer patients, people affected by immunodepression or severe comorbidity were excluded. So safety and efficacy data about this population are not available in this moment. Clinicians have to have to make recommendation based on risk-benefit ratio and on extrapolating data from the trial. But what society said about? ACO said that patients undergoing cancer treatment may be offered vaccination against COVID-19 as long as any components of the vaccine are not contraindicated. American Geriatric Society say that. Next slide, please. Next slide. Thank you. Perfect. The slide before. The slide before. Thank you. American Geriatric Society encouraged elderly to get vaccinated based on data concerning 20% of older patients in phase 3 clinical trial and at least 86% of efficacy in that age group. Next slide, please. So I will present to you the vaccine whose trial included elderly patients. What about Pfizer vaccine? The most important phase 3 clinical trial included 21% of elderly patients. The oldest participant was 89 years with a median age participant of 52 years. Next slide, please. Immunocompromising condition and patient treated with immunosuppressive therapy were excluded. Next slide, please. Systemic advent-evers and local one were pain, asthenia, headache, fever, but those advent-evers were less common in elderly patients than in younger one. Next slide, please. Next slide. Next slide. COVID-19 vaccine conferred a protection against COVID disease of 95% in overall population. Next slide, please. And between 95 and 100% in elderly patients. Next slide, please. Also, this vaccine met both main primary outpoints about efficacy and greatly exceeded the FDA criteria for authorization. Next slide, please. The phase 3 Moderna trial included 25% of elderly patients, with the oldest participant with an age of 95 years. Next slide, please. Next slide. The main criteria, exclusion criteria, was immunocompromising condition. And this vaccine, next slide, please, was better tolerated in among elderly group than in younger one, because injection site and systemic adverse events were more common in younger participants. Next slide, please. Moderna vaccine conferred an efficacy equal to 95% in overall population, 86% in elderly cancer patients, and a good protection among all group of age against severe COVID-19 disease. Next slide, please. Next slide. This phase 1 or the RADU trial, next slide, please, about Moderna, next slide, please, show that the 2-dose vaccine series has an acceptable safety and reactogenicity profile at lower dose and higher dose, with mostly mild to moderate local and systemic adverse event of short duration, which occurred predominantly among the younger group. Next slide, please. Next slide. Neutralizing antibody and T-cell, CD4 and CD8 responses that were observed in older group who received the higher dose exceeded the response to the lower dose and were similar to the response among younger participants who received the high dose. Next slide, please. Next slide. Next slide. Next. Okay. Sorry, the slide before. Perfect, thank you. The max vaccination in UK showed a reduction of risk of COVID-19 disease, of severe COVID disease and deep hospitalization, even in elderly patients and in against the English variant. So this data convince us to propose this vaccine in elderly patients, but there are some data about efficacy in elderly group. Next slide, please. Next slide. Perfect. Safety and efficacy of AstraZeneca vaccine were analyzed in 4 trials conducted in different countries. Next slide, please. Next slide. Next. Perfect. Elderly patients were included in COV2 and COV3 trial. Next slide, please. Next slide. The vaccine efficacy in overall population was equal to 70%, and this study, next slide, please. Next slide. Showed that vaccine efficacy was higher at 81%, with an interval between the first and the booster dose of 12 weeks or longer, than with a less, with a lower interval than 6 weeks. Next slide, please. Thank you. This phase 2/3 trial of AstraZeneca included 240 elderly patients. Next slide, please. Neutralizing antibody and CD4 and 8 responses was developed in 100% of in all patients at days 28 of follow-up. Next slide, please. Local and systemic reaction were more common in participants treated with vaccine than in those treated with the placebo, but less common in elderly than in young group. Next slide, please. Perfect. Okay. But the selection of participants aged 70 years and older without severe and uncontrolled medical comorbidity, or with a lower FLIGHT score and a median age of 73 years might not be representative of the general of our geriatric population. Next slide, please. Next slide. The phase 1/2 Johnson & Johnson trial. Next slide, please. Included, next slide, please, younger patient in cohort 1 and elderly patient in cohort 3, with a median age in elderly group of 70 years, and with the oldest participant age of 88 years. Next slide, please. Next slide. And next slide. Thank you. The side effects were more common, less common in elderly people than in younger one, but the immune response was lower in elderly patients because neutralizing antibody, anti-4, anti-CD8 cell response was lower in elderly group. Next slide, please. Next slide. This phase 3 clinical trial of Johnson & Johnson, their data aren't available in this time, but the first data showed that Johnson COVID conferred the protection, next slide, in preventing moderate and severe COVID-19 at 28 days after vaccination of 66%. Next slide. And 85 effective in preventing severe disease across all countries. Next slide, please. And a complete protection against coronavirus hospitalization and death 28 days post-vaccination. Next slide, please. Next slide. This study included 34% of elderly people, and protection were consistent in this group and across against the most part of variants. Next slide, please. The phase 3, the Russian phase 3 trial, next slide, please, included 1,600 patients, elderly patients. Next slide, please. With a mean age of 65 and the oldest participant aged of 87 years. Next slide, please. Perfect, next slide. The Russian vaccine conferred the protection against COVID-19 equal to 91.6% in overall population. Next slide, please. 91.8% in elderly group. Next slide, please. And 100% complete protection against moderate or severe cases of COVID-19 disease. Next slide, please. And the vaccine is safe because not serious adverse events were considered as related to the vaccine. Next slide, please. But there are of questions need an answer. Next slide, please. Next slide. In elderly, long-term safety, duration of immunity, and in cancer patient and in elderly cancer patient, safety, potential interaction with cancer disease and cancer treatment or other comorbidities that are frequent in elderly patients. Next slide, please. So prospective studies and data of the real world are required. Next slide, please. So I conclude with the last paper that I found, the first real data of cancer patients. The study was conducted in Tel Aviv and published on the Lancet Oncology. 145 patients treated with immunotherapy alone or immunotherapy associated with chemotherapy received Pfizer vaccine. The most common vaccine local side effects were pain at injection site, local rash, local swelling, and most common systemic adverse events were asthenia, ache, fever, gastroenterical complication, but their side effects were similar in cancer patient and in control group, in healthy control group. The only side effect was profile was different in in cancer patient was pain, muscle pain. That the paper showed that it was found more frequently in cancer patient than in control group. No immune side effects were reported. The most common local and systemic side effects were found after the second dose. There are the first result of the trial don't report the median age of participant, but I found that one patient was 87 years, and the oldest one was 93, and is received immunotherapy alone. Immunotherapy alone. Next slide, please. So I can conclude. Thank you very much for your attention, and thank you to Dr. Assad, the head of the COVID-19 board at Cancer Center Leon Berard, to help me for this presentation. And thank you, Nicolo and Anna, for the invitation.
Thank you, Chiara. A reminder to all attendees to please pop your questions in the Q&A box. Our next speaker is Dr. Lisa Cooper. She is an advanced fellow in geriatric medicine in Harvard Medical School, Brigham and Women's Hospital in Boston, Massachusetts. She completed a dual residency in internal medicine and geriatric medicine at the Rabin Medical Center in Petah Tikva, Israel in 2018. She is a practicing geriatrician and is conducting research projects in the field of surgical oncology and geriatric co-management and frailty. Thank you, Lisa. We can't wait to hear from you.
Sorry for that. Thank you so much, Anna, for that presentation, and thank you for inviting me to present today. I will be presenting today factors that affect the efficacy of vaccines in older adults. I have no disclosures. And our objectives today for my talk would be to discuss it in brief, the physiology of a very complex aging immune system. I would like also to touch a little bit about the immune frailty or frailty and immune response and whether or not there is a connection between the two. How can we improve vaccination responses in older adults? And at last, to finish with some frequently asked questions on vaccine efficacy and safety in older frail adults and some real life data. So I will start with aging and immunity, and obviously these are slides that you saw maybe somewhere in the past. I would like to start with the innate immune response. So the innate immune system is the first line of defense that we have against infections. It reacts faster than the adaptive immune system, but has no memory mechanism. And the main components of our innate immune system is the epithelial cells, the phagocytic cells, NK cells, and complement, and a variety of cytokines that regulate and coordinate immune responses. What happens to our immune system or to the innate immunity once we age? So the complement system is not very affected by aging, but there are several other age-related changes of the innate immune cells. And I would like to kind of show you some of them. So we do know that polymorphonuclears, their phagocytic capacity and efficiency of killing decreases. Macrophages also have decreased ability to kill pathogen and to present them, so it causes defects in CD4 T cell activation. And NK cells number increase with age, but their cytotoxic potential decreases. Having said all this, at most parts of the innate system are not significantly affected by aging. So even though these changes do happen, in a big picture, the innate immunity is not as influenced by aging, and this is as opposed to the adaptive immunity. So just to bring you back a little bit to physiology of the maturation of B cells and T cells, the lymphoid progenitor cells give rise to B cells, T lymphocytes, and natural killer cells. The B lymphocytes mature in the bone marrow, and then they go out into the circulation, into the bloodstream, and to the lymphoid organs. And this is different than the T cells, because our T cells leave the bone marrow immature, and they have to go into the thymus, where they'll mature, become T helper or T cytotoxic cells, and only then migrate into the blood and into the lymphoid organs. Some changes that happen to hematopoiesis with aging. So these are two pictures from bone marrows. I can kind of ask you what would be from an older adult and what would be from a younger patient. And basically the main differences that I think can be seen very clearly here is that if we look at a bone marrow of a 5-year-old, they'll have 90% cellularity and just scattered adipose tissue, as compared to an older adult that has 50% cellularity and 50% of adipose tissue. And this really means that there's fewer and less functional hematopoietic cells. And another point to consider is that the lymphoid lineage is far more compromised than the myeloid. And this is another reason why the adaptive immunity is disproportionately affected. The same kind of changes happen to the thymus, and that influences our T cell population. The thymus begins to decrease in size and is replaced by fat starting in our puberty, and this process is almost completed by the age of 40 to 50, and this results in a decreased number of naive T cells. So T cells and B cells both have kind of the same way to react to antigen, and this corresponds very nicely with the graphs you just saw by Chiara. We have our naive cells, and then they encounter an antigen, which causes an immune response by effector cells that at the end also have memory cells. And these memory cells, when they encounter the same antigen for the second time, are going to introduce a far more pronounced immune response, and will have at the end also more memory cells. And what happens when we age? So basically, the overall number doesn't change very dramatically, but inside of that, the proportion of cells does change. So if we look at the population of T and B cells of an older adult as compared to a younger patient, in the older population, we have much less naive cells, and we do have accumulation of memory and effector cells. Some of them are not as functional as they used to be. So what are the main changes to the adaptive immunity? We have fatty infiltration of the bone marrow that results in decreased hematopoiesis. We have thymic involution that decreases the pool of naive T cells. And the population of B and T lymphocytes contains higher proportion of memory versus naive cells. And this is, again, a kind of a nice summary to these two processes that happen at the same time once we age. On one hand, we have the immunosenescence, which is really the reduction in bone marrow, thymus, less naive T and B cells, less phagocytosis, and antibody production. And at the same time, we have the inflammaging, or the chronic inflammatory state that older adults do encounter. And that happens because of increased cytokine levels, myeloid cell numbers, and dysfunctional memory cells. And when we think about kind of producing or developing vaccines that are targeted to our older population, I think this paper from 2018 really states it very nicely, because at the end, we need to really consider these two processes. So vaccinations in the elderly has to take in consideration a delicate balance between immunosenescence, which makes the elderly less responsive to vaccination, and inflammaging. Is there a relationship between frailty and immune response? So there is some evidence, and I'll like to share it with you. So there is significant alternation in T cell subgroups, and it's graded across frailty levels. There is a decrease in the total percentage of peripheral blood B cells, and peripheral blood neutrophils and monocytes are increased, but the function is reduced. At the same time, we also know that there is heightened inflammatory state and increased IL-6 and CRP and WBC, which at the end of the day causes chronic inflammatory state that is associated with frailty. And this in turn causes dysregulation in both the adaptive and the immune system. The main question that still remains is whether or not this is the cause or the consequence of frailty. So we're still not sure whether it's the immune frailty that causes the frailty to progress or whether the frailty by itself causes these changes to the immune system. And what about frailty and the efficacy of vaccines? Does that influence the way that our older population or older frail population is going to react to vaccination? So there are mixed results, and it was mostly studied until now in influenza, though I'm sure COVID-19 is going to change the whole pendulum. So frailty did not, in some studies, frailty did not modify the immune response, and here are just some examples, while other studies show that frailty is associated with impaired antibody response. And just to kind of consider, frailty is a whole big topic that I can give a talk only on that, but we need to really understand that frailty can be measured in different ways. And in these studies, it was measured in different ways, which could actually influence the outcomes. So it's also a little bit hard to compare between these studies. And I like this quote from The Lancet in November 2020, because I think it summarizes all these thoughts together. A plan for how to consider frailty in COVID-19 vaccine development is important. Involving geriatricians could bring a key lens to assist with planning these ongoing studies, focusing on older adults and interpreting the results. So what can we do to kind of increase or boost up the vaccine response in older adults? So one thing is boosting, and as we saw, and we also know this from the COVID-19 vaccines, giving a second vaccine does boost the immune response. There are also some studies showing that the time of day of vaccine administration is important, and people that get vaccines early in the morning have better immune responses as compared to the afternoon or late evening. There's also some evidence about mitigating the effect of stress, because some studies show that stress and bereavement have negative impact on vaccine response. And what about improved adjuvants? When we really think about producing vaccines that are targeted for the elderly population, we have to think about development of vaccine adjuvants that are specifically designed to optimally stimulate the aging immune system, which can be tricky, as we just kind of understand. And exercise, the last but not least, this is a very important and exciting topic, but I won't talk more about that because you're going to hear about that from the talk after me. And I would like to end with some, I think, frequently asked questions or things that might have come up while I was talking today. So is there any real world data, and specifically for the COVID-19 and older adults? So the answer is yes, of course. Things are always changing in the world of COVID-19. And this is just one example from a month ago showing unanticipated efficacy of SARS-CoV-2 vaccination in older adults. So should I say to my 90-year-old mother to get the COVID vaccine? My answer would be yes, but I do want to stay humble and kind of say that although the results so far are very promising, and in the US, over 3 million nursing home residents have been vaccinated safely, we still know that the data is ongoing, and we're just looking into 4 months, which in kind of the big world of medical care is a very limited time. So what about the safety? So we're showing that the efficacy is probably pretty good, even for older adults, but what about safety? And I know safety concerns are an ongoing topic in different parts of the world. So I can only share for now what kind of we have in the US, and the CDC and the FDA are monitoring different drug reactions and specifically vaccine reactions. This is the last report that came out at the end of January 21, and hopefully soon they'll have an updated report because they're monitoring all the time the vaccines that are given worldwide. I think the important kind of encouraging point here, again, with the caveat that this is just the Pfizer and the Moderna vaccines that were available at that time in the US, a lot of concern came up around the anaphylaxis. And in this case, what we've seen so far is none of them were in older adults. The higher age was 63. And I would like to end with kind of two examples. One is a smaller example and one is a bigger picture. And my first example is from one organization in Massachusetts. Hebrew Senior Life has 2 nursing homes in the Boston area with overall 570 residents. As of April 1st, 2021, 97% are fully vaccinated by the Moderna vaccine. Healthcare employees in this institution are 73% fully vaccinated. And as of February 16, 2021, they have seen no new cases of COVID-19 across the 2 campuses. They have also not seen any severe adverse events from the vaccines, no anaphylaxis, no deaths or hospitalization. And they have seen some mild side effects, mainly cases of elevated temperature and a fall that they're not even sure that is related. I think the most promising thing from this kind of process is the fact that they have changed their visiting policies. We know that our older adults have been really affected, and specifically patients who or people that reside in nursing homes. With the lockdowns, they could not have their loved ones come to visit. And now with the vaccine policy and the rollout, since all their patients or all their people in these nursing homes are vaccinated, they allow now visitors. And visitors who come in and are vaccinated can fully be without any protection in the room together with the nursing home resident. And if the visitor is not vaccinated, he can still come in, but they have to keep the PPE and the social distancing and all the measures. But this is a very important aspect. And this is from the CDC dashboard. They do publish data from the US. And although I don't have here the data specifically about the vaccines, we can look here to the right. There are confirmed COVID-19 cases among residents in nursing homes. And you can see that the peak here was around December and January. Well, in the end of December, we introduced the vaccines and started to vaccinate with a high priority to nursing home residents. And as of the end of March 2021, the cases and the deaths are really reducing. This is, again, we can consider that it's contributed due to the vaccination. And this is from the New York Times. They have a dashboard on COVID-19, and this is specifically the vaccination rate. And this is updated to yesterday in older adults. And then across the US in different states, the numbers are a little bit different, but overall in the US, over 50% of people over the age of 65 are fully vaccinated. And because we do have an international audience, I would like also to kind of look at the world map. Again, the New York Times has a COVID-19 dashboard. So you can, if you're a data freak, you can every day click and refresh and get the updated data. The darker the green is, the higher rate of vaccination are. And I do want to kind of end on a positive note that vaccines are, hopefully the numbers of people that are vaccinated are increasing. And I hope that this will also soon we'll be able to see the positive effects on this on our older population. Thank you so much.
Thank you very much, Dr. Cooper, for the brilliant talk. It is now my pleasure to introduce the next speaker. Dr. Schroeder Sattar is a registered nurse and assistant professor at the College of Nursing, University of Saskatchewan in Canada. Dr. Sattar completed training at the Lawrence Bloomberg Faculty of Nursing at the University of Toronto. She worked with researchers from the University Health Network, University of Toronto, and the Grand Valley State University in the fields of falls in the older cancer patient population. She's now conducting clinical trials to evaluate the feasibility and efficacy of virtually delivered exercise programs on the improvement of lower body strength, balance, and fall rates in the older patient population. Dr. Sattar is an active SIOG member and the current vice chair of the Nursing and Allied Health Interest Group of our society. Dr. Sattar will discuss with us strategies to maximize the benefits of vaccines in older adults with cancer. Thank you very much for being here. Dr. Sattar, the floor is yours.
Thank you, Nicolo. Let me share my screen. For this part, we are going to particularly look at how to maximize benefits of COVID-19 vaccines in older adults with cancer, in particular with a focus on the role of trial inclusion and physical activity. I have nothing to declare. So the first part we're going to look at is the inclusion of older adults in vaccine trials and also talk about mitigating measures. So despite the fact that the COVID-19 infection has disproportionately affected older adults in terms of death and hospitalization, older adults are actually underrepresented in COVID-19 vaccine trials. This piece that is published by the JAMA, the authors reviewed 18 vaccine trials, and obviously it was done back in September. But at the time of the review, the authors looked at all COVID-19 trials, including vaccine trials that were registered on clinicaltrials.gov to evaluate the risk for exclusion of older adults. And this is what they found. The authors found that at least 61% of the trials included some form of age cutoffs, and the remaining 7 trials had some sort of broad, non-specific exclusion. So all of them were one way or another at high risk of excluding older adults. And these exclusions can really limit the ability to evaluate things such as efficacy, appropriate dosage, and adverse effects, and all these things. And subsequently, some efforts were made to include older adults, such as the Pfizer and Moderna and the Janssen trials, but there were still some issues in terms of representations of older adults and frail older adults in particular, and those that have comorbidities as well, and they were largely excluded. So when we think about this, frail older adults and those who may have complex comorbidities are receiving a vaccine that is based on limited evidence generated from trials that largely excluded the representation of this group. Take, for example, if we look at Pfizer. Now, this is their table 1. It says the median age is 52. Here, and it's really interesting. They provided a range, but there really isn't any report about the interquartile range or any standard deviation or anything remotely providing information on that. And another thing to look at is, I'd like to draw your attention on how they divided the age group. So here it appears that at first glance, there are over 40%, actually 42% that were older adults. And we all know that it may not be the best way to divide people based on 16 to 55 and over 55, because we know that adults who are 55 years of age are very different from adults who are 85 years of age. So that's one thing to keep in mind. Another thing that is really interesting is, and many of you who may have read this article may have already noticed as well, in particular, if you look at the 75 and older age group, the efficacy reported was 100%, which is fantastic. But when we take a closer look at the confidence interval, and clearly there is a sample size issue going on here with a negative on one side. And then when we look at the younger old groups, at first glance, again, it seems like the older than 65 group, the vaccine is more efficacious for them compared to the older than 55 group. Again, really there aren't a lot of people in this group to compare. And again, it's an issue that's very obvious in terms of sample size here. So if we really want to understand the long-term efficacy and safety of this vaccine, the only source of data that we can expect to find at this point would be waiting for retrospective data via a surveillance system and also from epidemiological studies. But given the devastating nature of this pandemic and how quickly it spreads, I may argue that this approach, meaning excluding older adults and older adults with frailties and comorbidities, may be justified because those who were developing the vaccine and running the trials would want to avoid anything that could potentially lead to pausing of the studies and any delays of this important development of this important vaccine. And also, when we talk about involving frail older adults or those who have complex comorbidities or medical conditions into randomized trial, and then it involves the ethics of randomizing this population who are extra vulnerable to receive potentially the placebo again. So there's a lot to think about. But moving forward, we know that from the research perspective, there is a need to expand the inclusion of older adults with frailty or those who have comorbidities to make sure that the data generated are applicable to this group. And there are ways to mitigate the risk of unnecessary and costly delays with judicious application of pause rules and other safety criteria, and also can also incorporate the use of non-randomized study designs for this population. And another thing that is important to take into consideration is it is possible to have better engagement and also collaboration between teams who are working on vaccine studies and teams who are experienced with conducting trials involving older adults with cancer, older adults with frailties and comorbidities. So to expedite the generation of data on vaccine safety and efficacy in this population is not impossible. Another thing to keep in mind is that from the research perspective, we need to also focus on investigating the long-term safety and also seroconversion, seroprotection rates in older adults and older adults with cancer, and particularly in the oncology setting. There's also a need to prioritize investigation of how aging, frailty, functions and cancer treatments, all these things, how they would impact cancers, how they would impact the vaccine safety and also efficacy and in terms of adverse effects as well. And if possible, it's a good idea to encourage patients to schedule their vaccination at the time of bone marrow function recovery. For instance, while the older patient is on chemotherapy, it may be ideal to schedule the vaccination a few days before the next cycle of treatment, not just to optimize the efficacy, but also to minimize any symptoms related to the vaccination, such as flu-like symptoms or any discomfort that could potentially delay the upcoming chemo. And also for patients who have just had a hematopoietic cell transplant or who has just received CAR T-cell therapy, who are typically also receiving some form of immunosuppressive therapy, the recommendation is that they could receive the COVID vaccine as early as 3 months after treatment completion. And for patients receiving more intense chemotherapy regimens, say for instance, those starting initial therapy for leukemia, the recommendation is to delay vaccination until their cell counts recover. And another thing to consider is corticosteroids and can be temporarily put on hold if possible. Obviously, it's on a case-by-case basis, but it's important to consider given their strong immunosuppressive activity as well. Sorry. So other things important to consider include incorporating frailty assessment into routine care for older adults with cancer, because we know that frailty is a key predictor for adverse outcomes and can also help guide decision-making for vaccination, in particular within the context of competing risks. Another thing important to keep in mind is effective vaccine rollout. Obviously, it depends on a number of things such as adequate supply, accessibility, and other things, but trust in the efficacy and safety of the vaccine is also important. And as clinicians, we are in a unique position to, as a source for patients and to educate them about the value and safety of the vaccine and encourage them to get vaccinated. And actually, according to a recent a survey that was conducted by the University of Michigan National Poll on Healthy Aging, over half of the respondents said they would get vaccinated if it was recommended by their physician. So something important to keep in mind. And obviously, we should also encourage caregivers, household members, and those who are in close contacts with older adults with cancer to receive the vaccine for protection of the patient. And also continue to advise patients and healthcare providers to continue to persevere with public health guidelines even after receiving the vaccine. So the next part, we're going to look at physical activity and antibody response in older adults. Now, the benefits of physical activity and on mental health and physical health are well documented in the literature. And exercise actually has modulating effects on antibody response and immune functions, and these are also reflected in enhanced cellular and humoral immune responses to influenza vaccination as well. Now, there appears to be a consensus in the literature in terms of an augmentation of post-vaccination immune response in older adults who sustain higher levels of physical activity over extended period of time. And this is based on a very recent report that was released by the Irish Longitudinal Study of Aging, which includes the literature review component and also based on a systematic review. And both reviewed published studies, including RCTs and cross-sectional studies that looked at physical activity as an adjuvant to improve vaccination response in older adults, and they have very similar findings, which is prolonged exercise in the weeks and months prior to vaccination. It's also called chronic exercise. Can help enhance the vaccine-specific antibody response in older adults. Say, for instance, in one study, it was found that aerobic exercise performed 3 times a week for 10 months led to higher serum antibody titers at 24 weeks following vaccination compared to control. Another study found that serum influenza IgG and IgM titers were higher in active older adults compared to older adults who were sedentary following vaccination. And this trial conducted with 60 older adults that investigated the role of Asian-style exercises, including Tai Chi, again, performed 3 times a week for 10 months, led to not only greater magnitude, but also duration of antibody response. What we're looking at here is the composite geometric mean hemagglutination inhibition antibody titers in each group at 3, 6, and 20 weeks post-vaccination. And we can see here, at 20 weeks, only the intervention group had significantly higher titers compared to pre-vaccination. And there are other studies that looked at seroprotection maintenance as well. So the reviews also report that the more prolonged the exercise regimens are, the better the immune response will be to vaccination. And also moderate aerobic exercise appear to be more effective compared to resistance training and flexibility training. And considering these findings, it could be suggested that physical activity improves response to the influenza vaccine. And also it stands to reason that when transferring these findings to the COVID-19 context, the importance of physical activity in the older adult population becomes highly relevant. And the TILDA actually recommends that adults aged 60 years or above should consistently perform some kind of aerobic exercise at least 2 to 3 times a week in the weeks and months prior to vaccination. But we all know that older adults often don't meet recommended guidelines for exercise, even in normal times. And the pandemic, as we all know, has caused significant disruption to usual routines. One of the biggest impacts of social distancing, these restrictions, is the reduction of physical activities in older adults, which include incidental physical activity, which are related to participating in community activities and daily activities like shopping, going out to meet with friends and socializing, and also reduction in formal exercise like going to the gym, golfing, or bowling, and other activities, or mall walking with their peers. And in the oncology setting, older adults with cancer have also been advised to minimize their outings for obvious reasons because of their added vulnerabilities being older adults and at the same time being patients with cancer. It is a double whammy here within the context of COVID in terms of the risk of being infected, also the negative outcomes of the COVID infection. So it's extremely important that older patients follow these advices and recommendations. So we know that the COVID pandemic is still going on, and with these talks about third wave and fourth waves going on in the world in different parts of communities, and also the rising of new variants, the COVID is not going to go away anytime soon. So how do we help older patients with cancer to stay active? One of the things that we can do is initiate discussion regarding physical activity and exercise during appointments, and research in the general population and also in the oncology setting shows that if the recommendation about exercise comes from a healthcare provider, in particular their physicians, patients tend to more likely to engage in exercise or being adherent to the exercise program. So it's important that we assess that routinely. Another way is to link patients or refer them to exercise specialists so that they can receive tailored advice in terms of the type of exercise, how best to start, how much to exert, and all these things. We can also refer patients to exercise programs and trials. And nowadays there are more and more supervised exercise programs that are offered remotely in virtual format, both commercially and also in research format as well, or research-based. So it's really helpful. But what if there aren't any trials available that we're aware of that are suitable, or maybe the patients are not interested in joining anything? They can still stay active in different ways, doing housework, pushing the vacuum cleaner or brooming the floor is actually considered moderate exercise. So that is helpful. And there are a lot of resources out there that we can use to refer for our patients to use. Other considerations include, again, safety, encourage the patient to warm up before exercising, be aware of their environment, stay hydrated, and wear proper shoes and clothing. And also advise that if they decide to exercise outdoors, continue to observe public health guidelines, observe social distancing, stay safe, and if they don't feel well, focus the energy on getting better. And at this point, you may ask, what if my patient has already been vaccinated? As Dr. Cooper has mentioned just now, in the US, over half of those who are 65 or above have already been vaccinated. And there is some emergent evidence. This study reported that the data collected from a cohort of 56 older women who were given an actigraph to wear on their wrist immediately after receiving flu vaccine, and they had to wear this device continuously for 14 days. And the participants were stratified into active and a sedentary group based on a number of steps that were taken and was recorded by the actigraph. And briefly, this is what the study found. The participants who walked more had greater post-vaccination expansion of monocytes and plasmablasts in the peripheral blood, and also had a higher induction of antibodies against the influenza B at 18 months follow-up. But obviously here, the biggest limitation here is that this is only one study so far, and this is not a randomized trial. So there is a need for more research on older adults and older adults with cancer to generate more evidence. And given the gravity of the circumstances created by the pandemic, it is conceivable that there will be more studies investigating this relationship. But in the meantime, doing something is still better than doing nothing at all. And given the benefits of exercise for older adults and older adults with cancer, and the fact that inactivity could lead to or could exacerbate a functional decline for patients who are receiving treatment. So it's really important that we encourage patients to continue to stay active. So just to sum up, we should encourage older patients to, again, stay active before and after they have received the vaccination. Encourage them to continue to observe public health guidelines, and we can advise patients to schedule strategically their vaccination to maximize the bone marrow recovery or the time of bone marrow recovery. And also in terms of research, there is obviously a need to include older adults, frail older adults with comorbidities, including those with cancer, into vaccine studies, and also to focus on pharmacovigilance and prioritizing of investigations. Thank you.
Thank you very much. Thank you very much, Dr. Satter. It was a great talk. So I think it's time now to open up the Q&A session. I see that there is one question which has already been answered by Dr. Cooper, which is great. And I thought I could start with a question for Dr. Russo on the first part, which is quite interesting in the context of what's going on at the moment with all this vaccine nationalism and all this controversy. So assuming that all these vaccines that you presented are readily available, is there any that you would recommend over other vaccines for older patients with cancer based on what we know about the safety and efficacy?
Thank you, Nicola, for your question. With safety and efficacy data in the trial today, I am feel as a geriatrician that work in a cancer center, I am feel to propose all vaccine to elderly patients. As geriatrician, I think that it's important to study vaccine long-term efficacy in frailty patients and in a large cohort of older patients. In the future, to select those vaccines then can be most effective in different profile of elderly patients and different profile of elderly cancer patients. In this moment, there are some data of the real world of my cancer center. Today, 1,200 patients received the COVID-19 vaccine, especially Pfizer and Moderna. But in the last 2 weeks, I meet a lot of patients that had an appointment to receive AstraZeneca vaccine, probably due to the problem with the link between atypical thrombosis and AstraZeneca vaccine that occurred most frequently in younger people. So, to conclude with this data, I think that I am feel to propose a vaccine, but as geriatrician, it's important to study efficacy and long-term safety in frailty cohort of patients.
Thank you very much, Chiara.
Thank you.
That's good. I've got a question for Dr. Cooper. How important is it to include measures of fitness and frailty also in the real world studies of the efficacy of COVID-19 vaccines, and how would you envision doing this? Thank you.
Thank you, Anna, for that question. So of course, my answer is extremely important. And I think that COVID-19 has kind of put a big mirror in front of everybody and kind of it showed us how important it is and how vulnerable on one hand our older adults are, but really our industries and our thought is still not targeted specifically for older adults. And I think this is a great example and a great opportunity too, to kind of try to incorporate frailty measures. And there are opportunities. I mean, frailty is a very complex construct on one hand. On the other hand, it should not, because it's complex, it should not just mean that we're not going to include it in studies. And I think there was an ongoing effort, and we should push more. And we should, as a medical community, also expect this, because if we're going to give these vaccines, give these treatments, and it's true also for the cancer world, we really have to continue our push to include these patients in studies and not just wait for real world data to come out. Thank you.
Excellent, Lisa. Thank you.
I'd like to ask one final question to Schroeder before we close. Obviously, there are quite a lot of data suggesting that malnutrition is prevalent in older patients with cancer, and this can also have a detrimental impact on, for example, their survival, even when this is limited. Are you aware of any data also on the influence of nutritional status, which is obviously a key component of comprehensive genetic assessment, on the efficacy of vaccines in general?
Thank you, Nicolo. Well, there is some data, but not from reviews, because there is actually very few generated in this particular topic. And some data seem to suggest that obesity may actually negatively affect the impact of vaccine response in adults, not particularly in the older population. And there is actually a trial that particularly look at in terms of the nutrients, micronutrients, and what the researchers they did was they provided a liquid form of mixed complete nutrition, including all sorts of vitamins and minerals for older adults. And it shows that it does help in terms of boosting their antibody response as measured by the HAI antibody titers. But again, that was only one study, and research in this area is still ongoing. Then hopefully there will be, again, more research done on this particular topic.
Thank you very much, Schroeder.
Thank you.
I think that's about as much time that we have for tonight. We thank our expert speakers for sharing with us your valuable insights, the attendees for your ongoing care in older adults with cancer, and to our sponsors and the SIOG organizers. Until our next webinar series, good night, everyone.
Good night.
Have a nice weekend. Thank you. Good night.